Hello and welcome. In this educational video on 12-lead ECG interpretation, we're going to talk about STEMI equivalents. This is a more advanced interpretation skill, so if you don't have that basic knowledge, please go do the 12-lead ECG course before continuing on with this video. So we should all be pretty familiar with what a STEMI is. A STEMI is an ST-elevated myocardial infarction. And in the clinical arena, we use a STEMI alert criteria to get a patient catheterized and reperfused. What we're basically saying is that there's an occluded coronary artery, and we can see that on a 12-lead EKG. In this example, should be pretty obvious to you that this meets what would be most STEMI alert criteria, depending on where you work. You definitely have some ST elevation, just starting with lead 1. You see some AVL. Those two leads are contiguous to each other. They're both considered your high lateral leads. Okay, and then whenever I see ST elevation in the high lateral leads, I immediately look over here at the inferior leads. Okay, and I do in fact see ST depression. So those two leads, AVL and lead 3, are very reciprocal to each other. So if I see ST elevation in one of them, I'm looking for ST depression in the other. And so we do have enough to meet STEMI alert criteria. We'd say this is a lateral wall MI with ST depression or reciprocal changes in the inferior leads. Furthermore, it looks like we might have some anterior ST elevation. Although it's more diffuse, I'd say that this is more obviously acute because this diffuse ST elevation can sometimes be one of your STE-Mimics like early repole or something like that. But that's not what this discussion is about. So that's what an actual STEMI is, and you should know that before moving on to STEMI equivalents. Here's another quick example of a STEMI. This one's also should be obvious to you. You have ST elevation here in these inferior leads and ST depression in lateral leads. So you have an inferior wall MI, and sure enough, you do have over here in these low lateral leads, you do also have a little bit of ST elevation as well. So it's an inferior lateral MI. And if this one's not obvious to you, I implore you to please go and review a STEMI course, 12-lead ECG interpretation course, and basic interpretation before moving on. But this one is, this is obvious, pretty bad tombstone-like ST elevation here in the inferior leads. Again, with reciprocal changes, you see mostly an AVL, and sure enough, you do also have the low lateral ST elevation. So even all comes all the way over here to V3. So this again is another inferior lateral MI. All right, so I suppose it's time to define what a STEMI equivalent is, and that kind of why it's important is also worth discussing as well. So a STEMI, as we know, okay, is something that meets a STEMI alert criteria, and this patient will typically go to the cath lab. Once it's called STEMI alert, whether it's in the field or in an emergency room, you then consult with the cath team and a cardiologist, and they decide whether they're going to take the patient. Usually, in your more advanced systems, just the calling a STEMI alert will get that cath lab activated and get that patient there pretty quick. An NSTEMI, or a non-ST elevated myocardial infarction, isn't saying they're not having an MI. What it is saying is they might be having an MI that doesn't show up on 12-lead. Okay, so basically it's ACS symptoms without STEMI alert criteria being met. And they may have an elevated troponin, but it's silent as far as the 12-lead is concerned, so they wouldn't have any changes on the 12-lead. And this patient will get your medical management or even get to the cath lab, but typically it's slower moving. Obviously, STEMIs get faster treatment because they're more recognizable. And then you have the STEMI equivalent. And your STEMI equivalent is a patient that they don't have a 12-lead that meets necessarily a STEMI alert criteria, but they do have changes on that 12-lead that are indicative of an acute coronary syndrome or a myocardial infarction. And they should go to the cath lab. They should get reperfusion therapy just as quickly as an actual STEMI. That's why we're calling it a STEMI equivalent. So the first one we're going to talk about is a left bundle branch block in the presence of a myocardial infarction. Now, the American Heart Association, God bless them, have really tried to catch these patients by utilizing this criteria of a presumably new left bundle branch block. And those of us that have been interpreting 12 leads for a while know that this is basically old, outdated criteria, despite this being a very updated version of the AHA algorithm, which uses this criteria. The research does not show that a new left bundle branch block is any more likely to be associated with a myocardial infarction than any other 12 lead. However, there are changes that you can look at on a 12 lead that indicate that the patient with a left bundle branch block is having a myocardial infarction. Now, depending on where you learn 12 lead ECG interpretation, you may have been told once you identify that the patient has a left bundle branch block, then you stop interpreting the 12 lead because you can't possibly identify an MI in the presence of a left bundle branch block. Well, that's an old myth, and I think it's kind of losing its weight in all these 12 lead courses, because most people that teach these 12 lead courses are familiar with something called Sgarbossa's criteria. So that's what we're going to discuss. So let's talk about this for a second. This is an algorithm that I found on Rebel EM. It's a nice website that provides a lot of medical education for free. And if you look at the algorithm, it's very intuitive. If you have a suspected acute myocardial infarction in the presence of a left bundle branch block, you move down the algorithm. Is the patient stable? If they are unstable, then you come over here and you see that you would just take them to a primary percutaneous coronary intervention center, all right, a PCI center. If they are stable, you move on down. Do they have a Sgarbossa criteria greater than or equal to 3? Well, you might not know what that means, but that is a specific set of criteria that can provide you with points. And if you have, the more points you have, the more indicative it is of a myocardial infarction. And of course, if you have a score greater than or equal to 3, you go to a PCI center. If not, you move on down to this STS ratio. And this is a modified Sgarbossa criteria. And that's what we're going to really talk about. And then if you didn't have that, you would do serial ECGs, serial troponin, all that stuff that they do in the hospital to make sure that this patient doesn't get inadvertently discharged before confirming that they're not in fact having some acute injury. And I put here an example of a left bundle branch block. And if you were to look at this left bundle branch block, would you be able to tell me if this is indicative of somebody that meets Sgarbossa's criteria or is having ischemic changes? Is this 12 lead look acute to you, or does this look like your typical patient that has a left bundle branch block and doesn't have any changes indicative of ischemia? So let's talk about that further. All right, here we go. Let's talk about Sgarbossa's criteria. Now, before we really get into Sgarbossa's criteria, you have to understand what T-wave concordance and discordance is. And to do that, let me go to this next slide here. So concordant ST elevation is when you have a QRS complex that's positive and ends in a positive wave usually, and then a T-wave that's also positive with ST elevation. You have concordant ST elevation. And whenever you see concordant ST elevation, that's typically more bad, okay? It's worse than discordant ST elevation. In the presence of LVH, a paced rhythm, or in this case, left bundle branch block, if you see concordant ST elevation of at least 1 millimeter, all right, then it's highly indicative of a STEMI or an acute myocardial infarction. And then you have discordant ST elevation, and that's when the T wave and the QRS complex are going in opposite directions. And usually you're talking about the last wave or the terminal wave of the QRS complex. Now let's look at the Sgarbossa criteria for this discordant presentation. Because when it comes to the concordant presentation, it's pretty easy. If you have 1 millimeter of concordant ST elevation or 1 millimeter of concordant ST depression, meaning that the QRS complex is negative and so is the T wave. So the T wave would be inverted and they both go down and they have ST depression. Both of those, if you have at least 1 millimeter, you have a STEMI equivalent. But if it's discordant, as it is in both of these cases, first we'll talk about this one here on the left. On the left, you have a QRS complex that's predominantly negative and the terminal wave is pointing down. And then you have a T wave that's pointing up with ST elevation. Okay, and to find the amount of ST elevation, we're going to find the isoelectric line here, and they're going to find that J point and measure in between them, and I wrote it down. It's about 5 millimeters of ST elevation. And then you have to see how deep, in fact, is this S wave, because we're using rules of proportionality. Okay, so we're looking for the excessive amount of ST elevation. Okay, so what we do is we take this isoelectric line and we continue that over to where the S wave ends, and we can go ahead and find the nadir of the S wave, which is the bottom. All right, measure that, and you get about 9 millimeters. In Sgarbossa's criteria, this is modified Sgarbossa's criteria from Dr. Stephen Smith, and this is a version. He's had several, and Dr. Stephen Smith runs Dr. Smith's ECG blog. He's a very smart guy and does a lot of research on EKG interpretation. So this criteria is, in fact, more sensitive, more specific, and better than the original Sgarbossa's criteria. And the criteria for ST elevation is if the ST elevation is 25% or greater the amount or the size of the S wave depth. So in this case, we have 5 millimeters of ST elevation in a 9 millimeter S wave. So that's at least 25%. You know, it's at least a quarter of 9 millimeters, right? 5 millimeters is more than half of 9. All right, so we do meet the modified Sgarbossa's criteria here, so that's indicative of an acute MI in the presence of left bundle branch block. So over here on the right, this side, we're going to see a positive terminal wave or positive QRS complex with an inverted or downward pointing T wave. Okay, and it's the same thing but in reverse here. All right, you're going to look for the amount of ST depression. All right, we have 5 millimeters, and then you're going to look at the R wave amplitude. R wave amplitude, and so that's going to go from the isoelectric line to the top of the R wave, and this one's about 9 millimeters. So again, 5 millimeters is at least 25% of 9 millimeters. So you also have ST depression that is highly indicative of an acute myocardial infarction. Here, let's look at an example on a 12-lead ECG. Okay, so in this example, we have a left bundle branch block pattern. It is a QRS complex that's just barely 120 milliseconds. It's supraventricular rhythm, which is important to identify. And then in V1, you have a predominantly negative QRS complex. And if you remember your turn signal method, whenever you push down on a turn signal, you're going you're turning to the left, or you're indicating that you're turning to the left. So this would be a left bundle branch block because V1 is pointed down. And so also you have nice positive R waves in leads 1 and V6. So this is not a non-specific intraventricular conduction delay. Oops, let's go back here. All right, so looking more at this 12 lead, let's just pay attention to the Sgarbossa's criteria stuff. Do you see any concordant changes? That's what I look for first, is the concordant changes, because I think those are more sensitive for an acute injury. And sure enough, if you look at lead 2, you have what we would call concordant ST depression. You have ST segment that's depressed in the presence of a negative terminal wave. Okay, so the QRS complex is negative, mostly negative, ends negative, and the ST segment is depressed, so that's concordant ST depression. And it also looks like you have some concordant ST depression over here in V4 and V5. All right, so all of that is indicative of an acute injury. Also, in V1, you may have noted some concordant elevation. Let me move some of these arrows out of the way so we can see. In V1, we have a little bit, maybe 1 millimeter of concordant elevation because that last wave is positive, and so is the ST segment. The ST segment is up. And you can even see in AVR, even though we don't use that one usually. We'll talk about that in a later slide here when we can use AVR. And this looks like maybe some concordant depression in V3. So all of that is highly indicative of an acute myocardial infarction in the presence of a left bundle branch block. All right, we don't see any excessive discordance. All right, no excessive discordance, but we have the concordance. So this is indicative of an acute injury. The next STEMI equivalent we're going to talk about is the Wellen's T-Waves. Wellen's T-Waves, sometimes called Wellen's phenomenon. And you have two possible presentations of Wellen's T-Waves, type A and type B. And type A is, probably the more commonly known. It's a biphasic T wave that goes up and then down, up and then down. So biphasic T wave that is up and then down, especially in the precordial leads. Okay, usually you'll see it in V1 through V3, and often it will extend all the way to V6. Okay, so that's type A. Type B is just an inverted T wave. All of these T waves here are inverted. And again, you'll usually see those in V1 through V3, but they could extend all the way to V6. And you could even see both type A and B on the same 12 lead. And this one, you almost see a little bit of type A here in V3. So what does this indicate, these Wellen's T wave? This indicates an acute, early acute myocardial infarction of the anterior wall, usually an LAD occlusion, okay? So typically you're going to see it in the precordial leads because, again, it's the anterior myocardial infarction. And you're going to see either these biphasic T waves or these inverted T waves that are called Wellen's T waves, type A and B. So let's just take a look at a quick example here of this 12-lead ECG that has Wellen's phenomenon or Wellen's T waves. And these T waves are, this is your type B pattern, so you have these nice inverted. This first one in V2 may be a little bit of a type A pattern. You see a little bit of a positive deflection before that inverted T wave. And all of these, one thing to note is these are symmetrical as well, symmetrical and inverted. So you also want to consider the company that it keeps, as Tom Bouthlet would say. And luckily, every 12-lead ECG comes with a patient. So let's assess that patient. And this patient should have ACS symptoms in addition to a 12-lead like this that would be a STEMI equivalent. This patient is likely going to experience a STEMI following this, but this is the acute pattern that they're presenting with. It's a nice early Wellen's phenomenon indicative of an acute myocardial infarction. The patient is in fact infarcting, and this is just before they're showing any ST elevation. Why I say to consider the patient is because these deep inverted and symmetrical T waves could also be a neurological pattern. Patients with hemorrhagic strokes could present with deep inverted T waves. So obviously, assessing your patient is going to help you to differentiate between a Wellen's T wave and somebody that's having a neurological pattern. Next, let's discuss hyperacute T waves. You may have some familiarity with hyperacute T wave. This is often an early anterior wall MI pattern, again in these precordial leads, but you could have hyperacute T waves in any area where you end up having ST elevation. So you could have them in the inferior leads over here or the lateral leads. And in this case that you see here, this 12 lead is kind of hard to see because it's older and it was a scanned image. But these T waves are broad-based and very tall. And again, when we see tall T waves, we should have a differential, a list of things that we consider. And one of them would be, of course, hyperkalemia, right? Your hyperkalemic T waves are also very tall, usually pretty sharp on top, as if you were to touch the top of them. As Dr. Amomatu says, you might prick your finger on a hyperacute T wave. However, again, I'd like to say consider the company that this 12 lead keeps. And again, we're lucky, every 12 lead comes with a patient. So let's assess our patient and see if they fit a more a hyper, kalemic presentation or an acute coronary syndrome presentation. In this case, the patient had crushing chest pain, with lots of risk factors associated with coronary artery disease. So this patient did make it to the cath lab. They eventually did have a STEMI, which makes it a little bit more obvious with that ST elevation. But this is the early presentation. The early presentation of that STEMI are these hyperacute T waves, usually broad-based, symmetrical, and very tall. And to talk about, I've mentioned symmetrical T waves now twice. Anytime a T wave is symmetrical, there's some sort of pathology going on. It doesn't necessarily mean ACS, but it could, and it just means that it's not a physiological normal T wave. So if a symmetrical T wave is present, something, some sort of pathology exists. Next, let's stick with T waves and talk about de Winter T waves, sometimes called de Winter's T waves. These are also a hyperacute T wave, Okay, so they're broad-based, tall, and symmetrical. But specifically with De Winter's T-Waves, you get J-point depression, especially in leads where you would usually see a little bit of elevation as a normal variant. So in V2 and V3, where we normally have this T-wave discordance that we learned about, we'd often see some ST elevation, maybe half a millimeter or a full millimeter of ST elevation. But here in this case, we have J-point depression. That J-point is below the isoelectric line with a broad-based, symmetrical, tall T-wave. We also see it over here in V4. And this T-wave is pretty dang big compared to that QRS complex, right? They should be pretty proportionate. And when you start losing proportionality like that, that's usually a good indication of pathology, in this case, an acute myocardial infarction. And I have the second. So this is the first 12 lead that was captured on this patient. And here's the next. And now we can see we have significant ST elevation. Of course, this patient now meets STEMI alert criteria. And if you were wondering, anytime you see an ST segment change that much in front of you, a dynamic ST segment should make you think acute coronary syndrome, and this patient needs to go to a PCI center. All right, so we saw that this patient went from these De Winter's T-waves with the J-point depression to this big elevation. And look at V4. Okay, V4, that's a tombstone equivalent. When you see a very small QRS complex and a huge T-wave, even with just a few millimeters of ST elevation, that is basically a tombstone. So this is quite certainly an acute myocardial infarction. Here's another great example of some De Winter's T-waves. Tall, broad-based. Now, this isn't as impressive as the last one, but you do see that J-point's depressed, and the T-waves are tall, broad-based, symmetrical T-waves, and certainly here where we would normally see ST elevation, V2, V3, seeing that ST depression should make us think something significant is happening. Okay, so again, these are STEMI equivalents. They should get treated the same as a STEMI. Now, based on your local guidelines, protocols, regulations, you may not be able to call it a STEMI alert or a cardiac alert or whatever phrasing you're using where you work. But, I would definitely advocate for the patient and get on the horn with the cardiologist, with the PCI center, and, report your findings and try to get the cath team moving on this patient. Next, as promised, we're going to talk about that lead we often ignore. As Dr. Amomatu always says, it's like the Rodney Dangerfield of 12 leads. It gets no respect. AVR, which usually looks out at that vector we call no man's land. But in some cases, it might be useful, especially when there's ST segment elevation in AVR. So if you ever see ST segment elevation in AVR, you should do two things. One, look for global ST depression. So look for ST segment depression in multiple leads on this 12 lead. And then two, look at V1 and see if you have ST elevation over there as well. If you have ST elevation in AVR that's greater than the amount of ST elevation in V1, that's highly indicative of a STEMI equivalent. And we're not going to be too specific, but it could be ischemia caused by a left main occlusion, a left main coronary artery stenosis, where that big left main, before it bifurcates into the left circumflex and to the LAD, if it becomes highly narrowed, obviously you're going to get decreased amount of blood flow and you're going to get ischemic injury. Or it could be multi-vessel or three-vessel disease, which is also not good. All of those should be considered STEMI equivalents, and this patient should get treated like they are experiencing a ST-elevated myocardial infarction. So again, let's look at another example here. And so we do see in that Rodney Dangerfield of leads that we have a little bit of ST segment elevation in AVR. It is more than the amount of elevation we have in V1. And then it's quite minimal and may be difficult to identify, but there is some ST depression on this 12 lead, and it is in several leads. So in this case, this would be a great 12 lead to transmit. And again, consider the company it keeps, as Tom Bouthillet always says. Every 12 lead comes with a patient. So assess that patient. If they're having ACS symptoms and they have this 12 lead that is pretty borderline for that STEMI equivalent, then send it on over and treat them as if maybe they're experiencing a STEMI. Here's another example where we see some ST segment changes. We see a little bit of elevation over here in AVR. It's also got that funky morphology where you wouldn't normally see an equiphasic QRS complex here in AVR. You see it with an inverted T wave like that. Makes the ST elevation kind of stand out. It is more than any ST elevation you see in V1, and you do see flattened ST segment depression in several of these leads on this 12 lead. So this is, again, highly indicative of a STEMI equivalent, which could mean a subendocardial ischemia due to a stenosed left main coronary artery or 3-vessel disease or something like that. So let's treat this patient as if they're experiencing acute coronary syndrome. Let's take a look at another good example because this is an important one. It's often overlooked. Again, we see ST elevation AVR greater than the amount in V1, and we see global ST segment depression. It doesn't have to be in every single lead, but it is in several leads, especially leads that aren't correlated to each other. They're not contiguous to each other. One thing to note about this finding is if you have somebody that's got a high rate tachycardia, we're talking in excess of 150, don't take that patient and use this criteria and call them a STEMI. You have to treat that rate. They could be having a rate-induced ischemia, and a rate-induced ischemic pattern looks a lot like this STEMI equivalent because they'll have ST depression in several of their ECG leads with elevation in AVR. And so you may be, fooled into thinking that is, like a left main coronary artery stenosis or an occlusion. But that's probably just rate-induced. You got to treat the patient's rate before, considering that ST segment depression. So that's it for the STEMI equivalents that we're going to discuss in this presentation. I'd also say that, there are other, like an isolated posterior wall infarction or an early inferior wall infarction that you may only see some ST depression in AVL. Those kind of things can also be considered STEMI equivalents. However, I think they more fit just the STEMI criteria if you truly know how to read 12 leads. But Rebel EM came up with a great way to remember the ones that I discussed and one that I didn't discuss. So how bad? So H for hyperacute T-waves. We talked about those hyperacute T-waves. Remember, they're broad-based, tall, and symmetrical. Okay? One that they list that I didn't talk about was out-of-hospital ROSC, simply because that's not, typically a 12-lead finding. ROSC stands for return of spontaneous circulation, so it was an out-of-hospital cardiac arrest that was resuscitated. That patient should go to cath lab. They should be treated like a STEMI, according to the ILCOR and ROC, the Resuscitation Outcome Consortium. The best treatment for the post-arrest patient is cardiac catheterization. That is the gold standard. And then W, Wellen's phenomenon, or Wellen's T-waves. Remember, that could be either those biphasic or those deep inverted symmetrical T-waves. And then, your left bundle, so B for bundle branch block with Sgarbossa's criteria. Remember, that was your excessive discordance or your concordant ST elevation. Meets Sgarbossa's criteria, in addition to excessive ST depression discordance or concordant ST depression. All of that left bundle branch block with Sgarbossa's criteria. And then A for AVR with ST segment elevation, again with that global ST depression. And of course, consider the rate. Make sure it's not a rate in excess of 150. And then D for De Winter's T-waves. Remember, De Winter's T-waves were J-point depression with the hyperacute T-wave. Okay, so remember how bad to remember all these STEMI equivalents and, utilize this information to hopefully advocate for your patient and have them receive expeditious care, get that PCI center care that your traditional STEMI alerts would receive.